I'd like to share a case diagnosed with chronic respiratory failure. Before the patient was referred to our medical center, he was hospitalized in the respiratory care ward of a community hospital. In these hospitals, patients with fever are often treated with antibiotics. Hence, when they are sent to our hospital, we may resort in using second or third line antibiotics. This patient came down with a fever on day 1 admission. Urine test was done and suggestive of urinary tract infection, as the white blood cell count was 12,870. Urine white blood cell was 2+, and large amount of bacteria was observed. We thus concluded this is a case of urosepsis. Prior to admission, blood cultures were collected in the emergency room and was reported positive with gram-negative bacilli. The resident physician proceeded to put patient on piperacillin tazobactam, a broad-spectrum antibiotic. During our initial ward rounds, we thought that the use of piperacillin tazobactam may not be precise enough. I was notified after of the positive blood culture and decided to proceed ordering a BioFire film array BCID2 test for the patient. The clinical laboratory provided a same-day test result. Per our suspicion, the patient was positive for E. coli. Much to our surprise, however, was that it also contained 2 antimicrobial resistant genes, OXA48-like and CTXM, as indicated within the report. As we know, with the presence of these 2 AMR genes, any use of carbapenems as treatment will be ineffective. We then discussed with our infectious disease colleague and decided to put the patient onto ceftazidime avibactam, which is a combination of the 3rd-generation cephalosporin ceftazidime and the novel non-beta-lactam beta-lactamase inhibitor avibactam. This antibiotic can be used to treat multi-drug resistant gram-negative bacteria, including Enterobacterales producing ESBL, KPC, AMPC, and OXA48-like genes. Whilst we know that it will be ineffective against Acinetobacter baumannii, but in this case we may be able to treat the patient with E. coli effectively. Ceftazidime avibactam has been made readily available in our hospital for some time, but we rarely use it. Often, effective antibiotic therapy are delayed following standard of care when patients are found to have carbapenem-resistant Enterobacterales. This results in deterioration in patient condition and may end up in palliative care ward. Fortunately for this patient, we were able to make the necessary antibiotic therapy adjustments and put him on ceftazidime avibactam precisely within 1 day of ICU admission. With availability and advancements in diagnostics and antibiotics, we should be able to make prompt therapy adjustments and not necessarily waiting for blood culture results after 7 days. If changes can be done on day 1, this may reduce antibiotic resistance and improve patient outcome. Based on guidelines of sepsis, it is recommended to administer antibiotics within 1 hour, emphasizing the importance of timeliness. However, it does not state that targeted antibiotics should be administered. This often results in the use of broad-spectrum antibiotics like piperacillin tazobactam, which is a common and preferred choice of resident physicians. Though promptly administered, it may be an inappropriate therapy, especially the antibiotic-resistant bacteria have become more prevalent. Hence, for patients with severe sepsis admitted into the ICU, we should begin therapy within 1 hour. However, I believe patients that have been given blood culture test prior to ICU admission, whether in emergency department or in the ward, wherever the culture turns out to be positive, we should order a multiplex PCR test as soon as possible. In our hospital, multiplex PCR test is not yet routinely performed, but only ordered additionally if blood culture turns out positive. With the addition of multiplex PCR results, we can have rapid bacteria identification and detection of antimicrobial resistant genes, thus enabling us to prescribe optimal treatment, not only more promptly but also more pathogen targeted.